Boys and girls, your attention, please.
First of all, I'd like to make a little statement.
Welcome to the Social Exchange Podcast.
All of your friends are welcome.
Once you learn the basic rules, it isn't really so complicated, is it?
Good manners make good first impressions. It's a simple enough matter to give people you meet plenty of room to pass.
Try to understand another person's viewpoint.
That's a rather simplified suggestion of a complex mental process. But you get the idea.
Welcome back to the Social Exchange Podcast. You're listening to a 3-part series called Where the Story Meets Pain. We are challenging, perhaps expanding upon, the standard story behind what we're calling an opioid crisis. It's the story that there is an addiction crisis and that pharmaceutical industries, prescribing doctors, and narcotic drugs are to blame. Last week we talked about the epidemiology of drug-related fatalities with a few different sources, one of them being Dr. Stefan Kertész, and we spoke to a chronic pain patient, Robert Rose, about not only drug deaths, but also the plight of pain patients. Now, let's further explore this corrective gone too far. What has the hard regulation on prescription pain pills done to a community of people who truly need them? Please enjoy the final episode of this series, Where the Story Meets Pain. This is episode number 3, Pain Patients. I feel like what I've done so far on the show is create a lot of dissonance without much resolve. So maybe we can start putting some of the pieces together constructively. How do we even begin to slow the rates of death that we see? Well, I searched the medical community for somebody who might be able to help me understand. I spoke with a lot of people, but then I was told I must speak with Terry A. Lewis, a woman whose life is now dedicated to answering this question. Dr. Lewis has a PhD in Rehabilitation Program Administration. She does mental health community development for people and healthcare and community programs that are unserved or underserved. I was told that she could spot a flaw in healthcare systems from a mile away, and when she does, her job is to help people, say, fix the leak before it gets out of control. Right now, she's using her expertise to implement sensible systems of care both in the U.S. and around the world. She graciously made time for a call. I couldn't quite get to her in time. She's in Taiwan, where she's consulting various organizations on how best to communicate and implement effective systems. She says she doesn't want organizations in other countries to make the same huge mistakes that we've made here in the U.S.
So I'm teaching in a rehabilitation program that's about 10 years old. I've been here for about 5 years, and I teach PTs and I teach allied health and physicians. So I'm teaching them how to think like systems thinkers as they design their community rehabilitation programs to move from hospital-based services to community-based care, and it's lots of fun because it's an entirely different culture, and working really hard to prevent them from making the same mistakes that we made in the U.S.
And so, what exactly are the mistakes we are making in the U.S.?
The problem that we are discussing in the media is not the problem that we have in community. And we cannot, I teach program and system evaluation and system design. So I teach how to design measures for different kinds of social and healthcare problems. And to do that, we have to be focused on the right stuff. We have to be working past our biases that are innate. We have to inoculate our thinking about what it is that we're trying to accomplish by teaching people how to use critical thinking processes and tools to prevent us from installing errors into our solutions. We're always looking for quick, easy solutions to very complex problems of community, and it's just not that simple.
Yeah.
So when we talk about the pill problem, um, that's not the problem we have. I mean, it's a problem for sure, but it is part of it's a very small piece of a much larger context. We cannot solve the pill problem by managing dose or forcing people to taper. We know that, we have that data, we know that that is true. We're just not paying attention to it because we're just so distracted by other bells and whistles that are simply demanding and sucking all of the air out of the room from a public policy perspective. We're doing a lot of servicing of the addiction versus the pain pill problem. Like, whose problem is more important and where does the problem begin? And we're asking the wrong questions. So I think that's kind of the place that I'm living in with this conversation. We have the data. We if we ask the right questions and we approach this from an entirely different place, by just sitting and looking at how communities are operating around these issues from a systems perspective, the answers are right in front of us, and we're not even looking at them.
Lewis echoes the other experts we've heard from, that we're fooling ourselves if we think such a widespread and complex problem with so many parts can be solved by a simple fix. And what we're doing with our healthcare system, especially as it applies to pain pill prescriptions, is implementing what seem like simple solutions, but which are making matters worse. So she says there are sensible solutions that would give us the kind of progress we want. But in order to achieve these solutions, we have to think about the way systems work together. And that's something she's been doing for over 35 years. I asked her what it takes to get people thinking in a systems way. Do you ever feel like you just don't have a razor's edge to stand on? Because, well, I guess I should ask, I assume you would think that originally, at least in some regard, pain pills were overprescribed in America. And so, like, if you say yes to that question, you almost can't get the word yes out without somebody on the opposite side of that coin saying, "Oh, wait a minute, the pain pills aren't the problem," and vice versa. So it's like you said you want to make sure that you're nuanced and thinking critically. How do you circle?
Well, here's the deal.
Yeah.
Yes, pain pills are overprescribed, but they're not. The problem is less one of overprescribing than of over issuing to the wrong people. We have one of the big problems we have in this discussion is that we're not looking at other indicators like medical harm. And if you think about that issue, they're related, and they're related as follows. Medical harm is creating about 400,000 new injuries a year. These are people who, like opiate naive users, that came to a medical procedure without, they had a problem that needed to be addressed, but they didn't have the problem they came out of their procedure with.
Right.
In many cases, we're burying that issue. And these folks come out of these procedures with critical harms if they survive. Many of these folks are folks that we're concerned about in the opioid discussion. That's number one. Number two, we are passing out. We have historically dispensed opioids in too much quantity for problems that could have been addressed in other ways. We do it because it's cheaper. We do it because insurance facilitates it, because the model of care that we're working through encourages us to do that. And it's not that doctors have done anything wrong. It's that they are working in a system that measures the wrong things. And our entire system is built to measure billing claims. It is not built to measure patient outcomes. So if you're measuring billing claims, then the method that we have used is extremely successful. If you're measuring patient outcomes, the method that we have installed sucks. And all we have to do is pull up the blankets and look under the covers, and we can see that data if we choose to look for it.
Is there a bandwidth problem to where if we decided to ask the number of doctors that we have now spend more time with patients addressing the things that ought to be addressed, that there wouldn't be the capacity to do so?
Well, we're killing the bandwidth. I mean, right now we've got an active campaign to kill the bandwidth. And because we're attacking the wrong problem. Our goal right now should not be to be taking doctors out of the system. Our goal should be to fix the system so that doctors can work properly and be supported within this system.
So we already have that problem just by virtue of trying to expend all of our energy on the wrong problems.
We're chasing the wrong dog, for sure. And anybody who wants to look at that can see that. I just am amazed that we're so far along in this discussion, and we're still not utilizing the practices that lead to effective healthcare measurement to assess and deploy people who know what they're doing into redesigning the system so that we can get to the problem we've got.
I asked Lewis, can you think of an ailment and give me an example of the way that is treated by standard care versus what she thinks true patient-centered care ought to look like?
Back pain. Back pain is a pretty good example of this. First of all, back pain is about 60 different problems, depending on where the complaint is lodged, what part of the spine. But the person goes in to the doctor. They may have had they've got poor seating in a work environment, or they've been on a production floor, and they've developed back pain over time. So they go to the doctor and they say, Doc, I got back pain and I've got to work a 10-hour shift, 6 days a week, and I need something to keep me going. So the doctor doesn't say, well, tell me about your work environment. The doctor doesn't say, tell me how you interact with your work environment. What the doctor does say is, well, I'll give you a muscle relaxer. I'll give you an anti-inflammatory. And if that doesn't work, come back next month, and I'll refer you to my buddy over here who runs a pain clinic, and we'll consider an epidural injection. Okay? So, so that pattern continues. The person, well, maybe the somas and the anti-inflammatories, they take the edge off, but they haven't fixed the problem. The problem is the way this person is interacting with their work environment. So maybe they need some environmental modifications. Maybe they need some assessment of their musculoskeletal system and some core strengthening exercises. Maybe they need, maybe they need a different workstation, or they need some assistive technology to help with lifting. Okay. So what we're trying to do is we're treating an environmental problem with a solution, a simple solution that doesn't solve the basic root cause of the problem. Worse, we're not even trying to find out what the root cause is. So then we go to we come back to the doctor in 30 days and say, Doc, I've still got, this is taking the edge off, but I still got the pain. So now the referral is made to the interventional pain clinic, and a series of epidural injections are scheduled. And maybe the first one doesn't work. Maybe the second one, 3 weeks later, it doesn't do much either. Maybe the third one in the series punctures the dura. Okay? So now we got a problem because we've created an injury. And we created an injury on top of a problem that exists that we don't know is there. So maybe that bulged disc that is giving this person some problem could have been managed by managing the person as opposed to managing the procedure. But now we've caused harm. Okay, so the person is out of work now for 6 weeks because we've given them a dural puncture. Then the workman's comp folks are saying, well, we'll pay for a surgery to go in and remove that bulged disc. So now you've got a situation where you're destabilizing an entire spine instead of addressing an environmental problem between the individual and the work that they are doing. So we see this. I see this all the time in case histories, and it bothers me. It really bothers me. It bothers people who are like me doing the same kind of work, because we know better than this.
Terry did spend a lot more time expressing her frustrations and explaining what we're getting wrong, but she is a woman of wisdom. She also had many suggestions about how we might begin to save lives, and in many cases the quality of those lives, which she said we might do by
simply doing good healthcare work. Not servicing the billing code, not servicing the throughput, but sitting down and talking to the person who's in front of you and finding out about how they work within their environment. I'm really concerned about that. And I think that one of the ways that we get to that problem is by our front-loading people who have different perspectives and creating a team of rivals, so to speak, who can supplement the work of the physician to have that conversation and build the data, build the information, gather the information, so that at the front end we can apply the very precious resources that we have to the right theory of the problem instead of chasing the billing code. If we do that at the front end, and we can do that at the front end, then I think that we build a system that is more resilient and less reliant on the income generated from medical harm, because we've built a system that is built much of its profit on return business associated with medical harms.
Do you think very consciously, like that's part of the business plan and the specs?
Absolutely.
Yeah.
I do. Yeah, I do. And many of us are concerned about this. I'm not the only one who's concerned about this. But I think that it comes down to what do we want for people? We want a healthy community, and we measure the health of a community by how the people who live there interact with its services and systems. So that's a pretty important idea in all of this. Even on the addiction side, is how do we want people who are vulnerable to have access to the same opportunities to be successful as those who have lots of resources and who are going to be successful because of they've got relationships working for them. So I think it's one of the most important problems we have in this entire discussion.
Dr. Lewis talked about the need to help everybody in the community, even, and she might say especially, the most vulnerable, including people with addictions or who might be vulnerable of forming addictions. Indeed, all of the experts I interviewed in the series will agree that we cannot simply avoid giving access to pain medications to people simply because they have or have had an addiction in the past. But there are mixed feelings among pain patients I interviewed about how doctors ought to treat or not to treat people with addictions. Many actually expressed their anger that they were being treated like, quote, addicts. One pain patient I interviewed told me, well, sure, if I was an addict, take my pills away. But that's not what I am. It made me realize that our healthcare problem is making people frustrated. Many have turned their frustration toward advocacy, though some have turned it toward whoever's easiest to target. Healthcare organizations are vilifying pills themselves, while many are going after pharmaceutical industries. And on the other side of that coin, people are angry with doctors, while many people are just not getting adequate care, and tired of being compared with people with, quote, actual addictions. But if we've learned anything from this series, it's that problems with the healthcare system are just that, part of a larger system. We could, in good faith, assume that there's not a single bad guy or group of bad guys, but we have a systematic problem. And this made me think of a woman I spoke to from Minnesota. Her name is
Star Selleck from Edina, Minnesota. I was blessed with a child that was full of energy and wanted to touch the stove in all ways possible. And when he was, the day after he turned 19, after having tried, I guess, heroin with some friends for a joke, or not a joke, just to experiment, just to see what it was, received a bunch of money on his birthday for his paycheck and his birthday collection, and decided to go out and purchase on his own for the first time, and came home and used and passed away. He was at home after I went out. I must have missed him by just a short period of time because I'm a nurse, and my immediate assessment was that he was pink, he was warm, but I could not find a heartbeat or breathing. So I called 911, said I can't keep talking to you, I've got to do CPR, and started CPR on him. It was within the first minute or two after that an officer came to my house, and it happened to be a police officer that had known my son for quite a few years and that I also knew. And I said, I think because I don't know what, I think he had told me 2 days prior that he had done this and that he was never going to do it again. And I said, he needs Narcan to the officer, and he looked at me and he goes, I don't carry Narcan. He had a defibrillator, but he didn't carry Narcan. And it was not too much longer, but the EMS came and they worked on him for about 45 minutes and then asked me to go to the neighbor's house, and didn't outright say he had passed away, but sort of said this is now going to be a crime scene, which I was able to put two and two together.
Star Selleck has encountered this problem from all angles. She used to work as a nurse and is quite aware of the many wonders as well as the difficulties of the American healthcare system. She is a chronic pain patient now, and she's deeply affected by new prescribing limits. which she'll describe in a moment. Starr is also involved in another area of this conversation, drug-related death. Her son died of a drug poisoning.
When Ian passed away, part of my grieving process was getting involved with an advocacy agency in my local area to advocate for change.
It's any parent's worst nightmare. Starr lost her son due to a drug death that may well have been prevented if the emergency rescue crew had carried Narcan, an overdose antidote that is known to save many lives. Starr became an advocate for harm reduction, including pushing for policies that would now allow emergency first responders and anybody else who wants it to carry Narcan.
As this movement has progressed, as we fought to get Narcan available, which is a harm reduction, dead people don't recover and all that, as we've changed laws to try to let people call if someone's in trouble and not get arrested so that few more people get help. I've fought for laws that everybody could carry Narcan. I truly believe and still believe in all those things. But as time has progressed, it has turned more punitive towards the folks that prescribe legitimately and that need legitimately. Now, I get it. There are doctors that are suffering from the disease of malpractice, and that they do it just for money. That's a malpractice issue, not necessarily something that politics needs to legislate. That the medical world will take care of people like that, given the information. But now it has gotten to the point where if I get to a spot in my life, I can give you some examples where I really need pain medicine and go in. They kind of force you to feel like you're like dirty in a way that, look at you like, well, why would you need pain medicine? People don't need that anymore. Probably about 20 years ago, I became infected with like a chronic Epstein-Barr and probably a chronic Lyme's disease. And over the course of time, it has affected my immune system and my joints and just given me generalized pain all over. But in the most recent years, it's severe arthritis that has taken me over in my neck, in my spine, and in my major joints except for my hips. And if you injure yourself while you've got one of those really bad arthritic joints, it can just hurt. That's all I can say. It really, really hurts. So I will use ice. I'll use heat. I'll try various forms of creams and gels. I took so much over-the-counter NSAIDs that it made this lining of my stomach bleed, so I'm not supposed to take them anymore. I take them in desperation when I don't have anything else to try and help. I am a medical marijuana patient. For me, for a lot of different pains, that works very well. Keeps things under control. But when you have one of those ones that's just like adding 5 more notches, I can't control it with that.
Remember, Starr herself is a chronic pain patient.
I have been sort of humiliated for even asking. And it's kind of a catch-22, although when I've needed it, I've used it in such a limited amount that I don't feel like I'm doing a dishonor to my son. But I have a feeling maybe of what people feel like when they're very, very marginalized. And since we've talked, I have spoken on trying to get to the root cause of what's causing my own medical issues. And I've been visiting with quite a few physicians. And in my discussions with them, I say, by the way, and toss it out there, and then they look at me, and a lot of them will say, don't think we're not thinking all those same things that you are. They are very unhappy with how much politics has started to legislate part of medicine.
Unfortunately, Starr knows firsthand what it can be like trying to negotiate for her own best interests with the likes of the United States healthcare system. Now, you had been going into different doctors for some pretty severe pain, you said. Might you talk about that?
Yes, there have been times where I have personally, I think I have a relatively high pain tolerance with having been sick so much. I also have a relatively high opioid tolerance just because in the last 20 years I've had to go off and on so much.
Yeah.
But I have gone, my two examples, I went to the doctor's in the ER at 6 o'clock in the morning and said I woke up in the middle of the night with this pain in my abdomen, and I can't really straighten out my leg, and I can't really walk on it very well. And I said, something's not right. And after I'm laying there for a while and it's throbbing a little more, I asked the nurse, I said, is there a possibility of getting anything for pain? And she said, I'll check with the doctor. And then they said, no. I said, okay. And then doctor came in and sort of said, well, your white count doesn't look bad and you'll probably be fine, but just to make sure we're not sending you home with something, we'll do a CT, which I'm thankful for. And I had my CT and I came back, and then they came in and they were hanging an IV and some things. I said, what are you doing? Oh, getting ready to run your antibiotics. I said, for what or why? Oh, hasn't the doctor talked to you? I'm like, no. And she said, well, let me get him for you because you're going to surgery in an hour. And I'm like, oh. So then he came in and he said, yeah, you do have appendicitis. I'm like, okay. And he goes, we need to take care of it right away. So within the hour, anesthesia comes in. And then I said, again, could I get something for pain now? Oh, yes, no problem. I'm like, don't need it until we prove that you really do, but you can't always prove what it is either. And then, I had a back issue where a disc I guess it can spew some kind of acid on your nerve when it's collapsing, and the nerve then feels like it's on fire all the way down, for me, to the bend of my knee, which I thought, this is torture. I can't live like this. They said, well, we'll do an epidural on Monday. We can schedule you for an epidural on Monday where they put medication in to calm that nerve. And I said, well, can you give me enough pain medicine to get to Monday? No, we don't do that anymore. And I thought, this is like a blowtorch on the leg. This is what pain medicine's for. 2 days. I said, that's within the CDC guidelines. And he's like, well, I don't do it anymore. Like, if you don't like it, leave.
She told me that she was in so much pain during those 2 days that she had to spend without pain medication that her mind went to extreme thoughts.
So I got in my car and I said, well, that leaves me with 3 options. 1, I buy illegally. 2, I say if this is what my life has come to, I don't want to do this anymore. Or 3, I'll try my family doctor because they've known me longer. I've been the same family doctor for about 20-something years. So I drove to my family doctor and pled my case, and with that feeling of, she's right, but I know I'm getting pressured not to do it, said, yeah, I'll give you 2 days of pain medicine.
She was lucky this time, and she's far from having an addiction, but Starr said she's terrified to be in that amount of pain, or even worse pain, in the future, and not have the ability to manage it. I don't know if you caught this. She described her pain being so intolerable during that time that the doctor wouldn't prescribe her pain pills, even for a few days, that she contemplated either buying drugs from the street or ending her life. This was the second time I spoke to her, and the second time she told me this. It's still hard to believe, given what I've learned about her. Far from the reckless type, Star is perhaps one of the most conscientious people I've ever spoken to. She would rather not take painkillers, and she's tried just about everything else. What do you say or think when somebody says to you, well, have you tried yoga? Or, Pilates, whatever, pain clinics, whatever.
Well, my thing is, then I tell them the list, and I can list things they've probably never heard of.
That you've tried.
I have gone to physical therapy. I've had massages done. I've gone to the chiropractor. I've tried various nutritional supplements. I've tried, and by physical therapy, they give you exercises to do at home to strengthen certain muscles. I mean, along the lines of the yoga and stretching, and I deepened my spiritual life. I take hot baths, tried all the turmeric, and I've tried medical marijuana. Might still be trying medical marijuana, but that's very price prohibitive, and I am a person that I've always lived within the law, so I want to continue to live within the law. I'm not trying to break the law. I was a nurse for 40 years, and I watched and listened to how this has changed over a 40-year period. And the thing in the hospital earlier in my career was that when you really need pain medicine, your body will let you know. Like, if you give them a little bit and it doesn't touch the pain, you give a little bit more until the person is comfortable. I'm unfamiliar with what you put out when you're in pain, but I know it kind of counteracts the narcotic effect to some extent when it's true physiologic pain, not just craving for the narcotic, but true pain stimulates the body in a way that very rarely did we see any adverse effects from giving it.
We've now heard stories from 2 chronic pain patients who struggle to find adequate care for their conditions. They are 2 quite patient, kind, and articulate human beings, and I can't say with any certainty I'd be able to reciprocate if our roles reversed. I can't help but wonder, could there be anything worse than being in consistent pain on the one hand, not getting adequate care on the other hand, and all the while feeling sad, isolated, maybe even guilty that I couldn't participate in life's events the way I once could? Well, pain patients and advocates on behalf of pain patients are slowly becoming louder and better known. Some have started showing up to social and political functions to speak on their own behalf, and on the behalf of others who couldn't be there, or on behalf of others who have died. Listen to this clip of a representative from the CDC. I'll give you some context in just a moment.
Thinking about those patients that are already on high dosages, are there ways that tapering could be incorporated?
But why are we tapering if they're safe, if they're already in stable treatment?
The first person you hear speaking is Dr. Jan Losby, a behavioral scientist speaking on behalf of the CDC. She's speaking here at a function called the National Prescription Drug Abuse and Heroin Summit. And she seems to be defending the CDC prescribing guidelines. The woman questioning her is an audience member at this event. Her name is Lauren DeLuca. She's the founder of a nonprofit called Chronic Illness Advocacy and Awareness Group, CIAAG, an organization which advocates for the rights of chronic pain patients to receive sufficient medical care.
And you stated in this show that this was for primary care settings, not disease patients. It's being applied to people with complex diseases. They're dying at 40 a day. And that's that's an epidemic.
So looking at individuals who are already on higher dosages than 90 milligrams.
That's not what I said, though.
So those individuals are at greater risk for overdose.
That's not what I asked. I asked, what were you going to do to protect people who need it? I didn't ask about 90 milligrams. I didn't ask that.
Collaborate both with commercial and public payers, and they're making the decisions around access to care. CDC is not...
Well, everybody's saying that they're doing it because you guys said. Every stakeholder is stating the CDC is the reason they're doing all these things at the law, at CMS, at the pharmacies. So there are about 30% of our population is disabled, elderly, and impacted potentially by these decisions. We can see in the numbers that this is now a fentanyl crisis and a heroin crisis, which we have, and I greatly respect the work done to prevent that. So please don't take that the wrong way, but there's a huge population that we're not even inviting to the discussion. You're cutting and throwing people off their medication against their will, not you, but everybody is citing the CDC is the reason to do it and saying, too bad. When people are complaining, saying, I'm getting sicker, help me, and then they get thrown into psych units against their will. I started a nonprofit. This is from real people. This isn't a made-up thing. I get emails every day from people on the streets basically telling me they're going to kill themselves because they can't get medicine from their doctor anymore. They go to the hospital, they get told they're a drug addict and laughed at. When they're in an emergency, life-threatening situation, and everybody states, I'm sorry, but the CDC says. Not one study was done for over 12 weeks. So 12 weeks is your long-term chronic pain, and you don't have studies over 12 weeks. So I respectfully ask, let the people who are being affected into this conversation, and seriously into this conversation. Not just, I know and I understand. No, you don't understand what it's like to wake up every day and not know if you're going to live or die because someone else is going to believe you or not.
Lauren DeLuca and the folks at the Chronic Illness Advocacy and Awareness Group understand that good, basically helpful people work at the CDC, and they just want them to know that there are some who require opioid painkillers if their pain is ever going to be manageable. When those people are cut off from their prescriptions, they're miserable at best, and they're committing suicide at worst. As you might imagine, there's a large body of people in pain, praying that the efforts from Lauren and such other advocates might begin to turn the tide of inadequate care that they're currently receiving. I am also hopeful that efforts will be constructive, but I'm not a chronic pain patient. I have a different basis. I had an addiction to opioids. I've been to the hospital for episodes related to drug mixing and drug poisoning in the past, so on a personal level, I worry that if I have terrible pain in the future, much like some of these folks have now, I may also receive inadequate pain care because I've been flagged as someone who may misuse the medication. I don't currently take drugs, and it can hardly be said that I have an addiction to any, but I can certainly think of circumstances in which taking opioids for pain would be my best option. So one thing's clear, the CDC prescribing guidelines, as they were weaponized, have been intolerable and inhumane for many, including chronic pain patients. But are they okay when applied to people with addictions or past addictions? I spoke again with Dr. Stefan Kertész, this time in person during his visit to my hometown.
For a person with addiction, the view of it as a disease may very well help to justify a biological therapy. That's helpful. There are a lot of people who actually need a biological intervention. Conversely, it turns out that for a lot of people, even if it isn't required, medications alone are not the end of the story of what constitutes human recovery, where you have to regain access to a life worth living. That requires a certain investment from all of us. And oddly enough, the thing that we often have trouble dedicating ourselves to, both with patients with chronic severe pain and people with addiction, is engaging them, asking, how can we help you make your life work in a constructive way, and then trying to deliver on that. And you have to engage those people as partners rather than as those people. The very expression itself kind of sets people with addiction and people with pain as some sphere outside of us, as if they don't have a say in the policy deliberations that we are having right now.
Dr. Kertész begs that we all begin to entertain a more complex look at our prescribing situation, including the way that we think about people with addictions. I asked him, what will have to be done to turn things around in this realm of the medical world?
Right now, physicians, as the prescribers that our society allows to prescribe opioids, they're under extraordinary pressure. There is no agency saying that they have safe harbor to prescribe, and they feel under extraordinary pressure. Normally in medicine, What we want for doctors or other healthcare clinicians to do is to make decisions based on an evaluation of what's most likely to help a patient with consent based on evidence. Right now, we are acting in a way that involves discarding evidence, discarding consent, and making decisions based on what will protect the physician. That's three pillars of what should make for good medical practice that we are allowing to be sacrificed. And the only way to restore those is for the authorities, government regulators, state regulators, professional societies, to stand up clearly and say, we don't want you to harm your own patients. You have safe harbor if you think it's necessary, based on careful practice, to provide these medicines, even if they are controversial. And even for people where 10 years back, we wish we hadn't started them, but now they're stable, there needs to be a clear statement of safe harbor for the clinicians, or they're going to continue to essentially abandon their role in medicine.
You know, there is a totally different species of argument that is fairly popular. It's a more utilitarian or consequentialist view. It's what's called a greater good argument. The premise is that cuts in prescribing rates are causing more people to be saved and causing fewer people to suffer and die. Therefore, continuing to cut prescriptions is what we must do. Well, by this way of thinking, people assume that one, whatever is the greatest good that can be done for the greatest number of people is the best, and two, that we have some idea about how to act that will do the most good for the masses. I've talked with many people with such arguments. I disagreed. First, it's not clear that cutting pain prescriptions is helping anybody. Rates of death are higher than ever, and rates of prescribing are down. And even if the trend was going in the other direction, if fewer people were dying than ever, people in pain and who can't get relief, they matter to me. People like Robert Rose and Star Selleck matter to me. And even if they didn't, pain is universal. A family member could be in pain, my mother and father. Do I care if they get adequate care? And who knows if I begin living with a severe and chronic pain? Even if nobody else mattered, I matter. The fact is, we're not doing the most good for the most people. But if we were, that's still not a premise I would choose to follow. It would be as if we were living in a 21st century medicalized version of the lottery or the Hunger Games. Except we kind of are, and this is real, and it's not entertaining. But there are people who live by such a moral code, and I've talked with them. Many of them are doctors themselves. Dr. Stanton Peele was my first guest on this series, and he'll get the last word. I asked him, how do I get an otherwise sensible and good doctor to understand the importance of, to experience empathy for people in pain?
Who decides that? I guess if I were really being incisive, I might say to the person, who made you God? These drugs exist. People can get them one way or another. You have the power to give them to people. How do you get to decide that other people should experience pain up to the point of wanting to die? Who made you? Who gave you that right?
Do you think that they're not exercising free will to the greatest extent because of pressure from organizations that were ostensibly just suggestions, but it's like, it's the CDC, so doctors are going to listen to them? Do you think they're under so much pressure that they are now in dissonance like that?
Oh, absolutely. Jacob writes about that, and
here he's referencing Jacob Sullum from earlier in the episode.
It's clear doctors have been persecuted and prosecuted. Everybody, the standards have been laid down, and you're aware of the New York Times article where a whole host of pain, not addiction experts, pain experts say, who's coming up with this kind of thing?
Mm-hmm.
Based on the idea that most people who take these drugs don't become addicted, and that people really suffer without them. By the way, one person who I often quote, certain people I'll never be able to say a bad thing about. There was a governor's conference in New England. All 50 governors voted for making it harder to get painkillers. And one person got up and said, well, why are you doing that? What about people who are genuinely experiencing pain, whatever kind of pain that is, physical or otherwise, psychic? And what about people who could be said to be addicted already? How are you going to deprive all of them of these of these remedies. And so the person who said that didn't have a vote in the governor's conference. It was a 50-0 vote. The person who said that was Barack Obama. And so sometimes I have to say, Jesus, God, this was the president of the United States. It's sort of like you think, well, wouldn't it be great if the president of the United States was the smartest person in the country? It's a humanistic point of view. It's a clinically effective point of view. And we're creating among people who are supposedly, like Maya, the most forward-looking people, we're creating a whole new drug wars mentality of forbidding people to use drugs who want to use drugs, and we're coming up with, well, they're addicted. That's the fundamental distinction. Addiction is a way of saying, well, people want something that they don't want. And then we have to go against a model of saying, well, people take things because they fill a purpose in their lives. Some of these things are pain that they can't possibly avoid. Some of these things are pain that if we're a clinician, we can help them to try and overcome. But it's their self-motivated behavior. Addiction is purposeful behavior of one kind or another. Versus addiction as a mechanical reaction, supposedly, to chemicals in a drug that interact with your brain. And we're back to the same old model of thinking, which is remarkably resistant to eradication, despite overwhelming data like Maya and others present, that in large majority, people deal with addictions on their own, including overcoming them. It's now impossible to do much better than allowing a doctor to make clinical decisions about an individual patient. We have in place check systems for people who are going around shopping narcotics, and we have check systems against narcotic mills. But those are two extreme points, and other than that, allowing individual choice under well-informed conditions and under positive controls is the best we can do. We had the best system in place. And that the largest source, as you described in the woman who was bawling her eyes out, people die from mixing drugs they shouldn't mix, which occurs primarily because they're taking tainted samples of drugs on the street. We're driving people in exactly the wrong direction. And the data tell us that. The latest CDC data going into September of 2017 showed that there was a 38% increase nationwide of emergency room referrals due to drug use. We're going off a cliff like lemmings. We're seeing people, we're seeing outcomes that grow increasingly worse. And because of a misstated model of what's going on, we're running faster towards that cliff. So on the one hand, we were doing as well as we could, allowing people to have supervised drug use. We could expand that by having heroin maintenance sites or heroin or drug use sites where drugs are tested and people administer them under healthful conditions. And in a broader sense, we have to eliminate the linkage between drug chemical structure and brain structure equal addiction to have a broader comprehension of what addiction is about and how we should conceive and respond to it.
I have one last question for you, though. I imagine that you don't think, like I don't think, that lawsuits against, say, Big Pharma are particularly useful, but I sense that there is a correct level of energy being allocated towards some kind of a problem. People are angry. What's your message to people who have the right amount of emotional salience involved in the issue, but who are spending their time and effort doing something so counterintuitive as to go back on pain pills, Big Pharma, things like that? What could they be doing instead, the standard person out there?
We should go against the triad of demonization, of drug scare, and of pharmacalizing addiction. You take a look at the broader person. Don't blame addiction on some external source. Along with demonization, it's externalization. look at each person's life, which is what a good doctor does and what a good clinician does, and allow yourself to understand their situation and help them to guide themselves through their own best way of using what's available to them.
We've done a romp through a complex social issue, and we've gained necessary insight along the way. We've learned that our standard story about addiction and drug deaths is misguided at best. Politicians, public health officials, and media reinforce a caricature of drug use by publicizing accounts of the most severe examples of addictive drug use that they can find. This approach has been the rule of thumb during our current opioid crisis. But as with the old drug war hysteria, so much of what's behind the new drug hysteria is incorrect. It's always important to be mindful of the risks of prescription drug use, like any such powerful experience. But we see that painkillers are, astoundingly, not particularly dangerous or lethal in general populations. Of course, it makes sense. Nearly all of us have taken painkillers like Percocet and Vicodin at some point. How then can our primary approach to the opioid crisis be to make it harder for those with opioid prescriptions to obtain the needed supplies? This has demonstrably had the effect of increasing opioid problems, since people have been forced to turn to illicit street suppliers of both painkillers and heroin. The fundamental mistaken idea about addiction that the painkiller scare reveals is that following the regular use of narcotics, addiction must follow. But that idea is no truer than the suggestion that regularly eating or having sex, shopping, will cause addiction to those things. The truth is, addictions are only created when an involvement develops a special place in or meaning for a person's life. Constant messaging, like that issued by the CDC, and most politicians will help to ensure that America views addiction as an inescapable, almost unavoidable consequence of using drugs. They say these things not only because they are chasing funding and votes, but unfortunately because they actually believe them. But the facts contradict these beliefs. Like many other involvements, drugs can have powerful negative consequences, but they usually don't. Painkillers are an effective way to offset chronic pain. But the medical establishment can't seem to resist the cultural tidal wave that now rejects this truth. Whatever your beliefs about this issue, it's clear that there are social problems to be solved, and the well-being of our fellow citizens is at the heart of the matter. And like all political issues, it's up to the electorate to become educated on these issues. That's you. If you'd like to become more involved, please follow the links posted in the description below, or you may write to us at The Social Exchange to engage in further conversation. We at The Social Exchange Podcast thank you for listening to our series, Where the Story Meets Pain. A million thanks for the time and for the wisdom of all of our guests. Until next time.